Morning.
Hi, good morning, everyone. Welcome to our
Morning. Good morning.
183rd session of International Weekly Meeting sponsored by SIMAO. Today, we have a very important topic on diabetes. To introduce, we have Dr. Monica. She will introduce the speaker. Over to you.
Thank you, Saurabh, and thank you to Samao again for this weekly meeting. It is my privilege to introduce our esteemed speaker, Dr. Jaydeep Khare, a highly accomplished endocrinologist located in Bhopal. Dr. Khare serves as a professor in the Department of Endocrinology at the People's College of Medical Sciences and is the director of the JSS Hormone Center. He also holds the position of the Joint Secretary of the Madhya Endocrine Society MP chapter affiliated with ESI. With many years of clinical and academic experience, he has received numerous accolades, including the Best Thesis Award in 2013, the RSDI USV Award for Excellence in Diabetes Care from 2019, and the International Healthcare Award 2020. Dr. Khare is a prolific contributor to the field with 32 publications in peer-reviewed journals and 3 book chapters. He is an active member of the editorial board in endocrinology and medicine journals. Please join me in welcoming Dr. Jaydeep Khare as he shares his insights and expertise with us today on an important topic on the diabetic implications on renal and cardiovascular health. Welcome.
Thank you, ma'am. Thank you, ma'am, for the kind words. And without wasting much time, I will start my session on the important topic, which you have already told that it is something which is the need of hour. And as we all know, that the prevalence of diabetes is increasing, and it is now one of the biggest pandemic which we are facing right now. So earlier, till 2011, it was like that glycemic control is very important. And once we tried to achieve good glycemic control, still the morbidity and mortalities were not very well managed. So we humans are always curious. We want to learn more. We want to achieve more, and we found out that something is missing out. Still the cardiovascular and other complications are not coming down. So the method of investigations, the improvement was there in investigations, the improvement was there in medications, which can help us in overcoming these shortcomings. So in a brief introduction, we all know that diabetes is a progressive disease, and it is characterized with the progressive loss of beta cell failure. Whether type 2, type 1, type 1 is actually an autoimmune disease, type 2 is a disease in which there is progressive failure. And by the time when the diagnosis of diabetes is made, approximately 70 to 80% of beta cells are damaged, and the production of insulin is not there, and it may be associated with the insulin resistance, which is characteristic of type 2. There are other types of diabetes also, but I will not be going into those details right now. And this is the IDF Atlas, which we have seen several times, and which says that 530 million population is living with diabetes in world right now, and which may increase up to 783 million by 2040. And if we will talk about the Southeast Asian population, right now 152 million population is living with diabetes, which may grow further by 2045. So in Indian scenario, as we are becoming the diabetes capital, there was one big study by Dr. V. Mohan sir at ICMR India study, which have shown that approximately 100 million population is suffering with diabetes in India, and the mean HbA1c is 8.9, which is very, very bad. And that it means that the patients are not having good glycemic control, and approximately two-thirds of the urban patients are not able to achieve the target HbA1c. And in that study, they found out that 100 million is suffering with diabetes and 136 million are pre-diabetic, which may burst and which may become diabetic in near future if proper lifestyle intervention is not done. So we are just sitting on a bomb which can explode anytime, and if proper lifestyle interventions are not. This was an old data which says that approximately 10 lakh people die with diabetes related complications. So it accounts for 2,700 deaths every day, which is a huge number, and a huge expenditure happens on the diabetes related complications. So, this is the ominous uptake of type 2 diabetes, which we have seen several times. What is the possible pathophysiology which leads to hyperglycemia and leads to several complications? And now we have several molecules in our armamentarium to control this hyperglycemia, to achieve good glycemic control, to prevent complications. Even after achieving good glycemic control in several patients, it is not being done. So, what are the complications which we commonly see? There can be acute complications, there can be chronic complications. Acute complications are something which happens very suddenly, which has to be managed very nicely, immediately on emergency basis. Otherwise, it may lead to very high mortalities like hypoglycemia, ketoacidosis, and infections. Chronic complications are something which patients will not appreciate initially. They will be like that this happens very frequently. It is my routine practice that I feel like burning sensation, or I there is frothing in my urine, or I get ulcers which don't heal very properly. This is chronic complications. They will not take care of it until unless it becomes severe. So these chronic complications are something which also has to be taken care of. So today I will be mainly talking about the micro and macrovascular complications, which are largely because of hyperglycemia or dysglycemia. But there are other factors also like oxidative stress, which can lead to, there is a glycemic variability, which can lead to these complications. So at present, when we see a patient with diabetes or people living with diabetes, these are the key parameters in our management, that we advise them for good nutrition, that this should be avoided, this should be taken. We advise them for good physical activity to reduce the insulin resistance, to improve the insulin output, and then we advise for the medications depending on the profile. It can be injectable, it can be oral, because every individual is different and we have to manage them accordingly. And there are landmark trials which have shown that if we reduce HbA1c from the baseline by 1%, then the death related because of diabetes comes down by 21%, microvascular complications come down by 37%, myocardial infarctions come by 14%. This is good, but still it is not 100%. So something is missing. So initially, as I was talking about, there was a triad for the management of diabetes. Glycemic triad, that HbA1c should be under control, fasting plasma glucose level should be under control, postprandial plasma glucose level should be under control. But still, we were not able to get the desired result. Still, something was missing. So, the two new parameters were added, that we should look after glycemic variability also, and the episodes of hypoglycemia, which can also increase to the morbidity and mortality. So what is glycemic variability? I will just give an example here, that suppose if mean HbA1c of someone, or mean blood glucose level of someone is 120. It can be 100 and 140 mean also. It can be 60 and 180 mean also. So 60 and 180 is something which is glycemic variability is very high, which leads to oxidative stress, which may lead to several complications. So it should be avoided. So now the newer concept with this is coming in time in range. So we should try to have the blood glucose levels, plasma glucose levels in range, what we have decided, what the treating doctor have decided for our their patient. And hypoglycemia is something which is very terrible, and it is as terrible as hyperglycemia, because once the patient episode, it is a severe acute complication, and once the patient experience hypoglycemia, then he is or she is so much worried that they don't take care of their blood glucose levels very strictly, because they feel like that if another hypoglycemia will happen, severe hypoglycemia will happen, they will not be able to survive, because this is like near death experience several times for several patients. And there may be several stress responses, inflammatory responses, impaired memory, confusion, loss of awareness, and several factors comes into play. And then that patient is not willing for good glycemic control in near future. So now coming to today's topic, that type 2 diabetes is frequently, or type 1 diabetes is frequently associated with several comorbidities. And there are studies which suggest that patients with diabetes have 60% more risk of heart failure if they have CKD, and 30 to 35% patient with heart failure has CKD. If so, and 20 to 24% patients with type 2 diabetes have CKD, which is a huge number. And 14 to 12 to 45% patients with type 2 diabetes have heart failure. So, if the patient is having diabetes, then it indirectly increases the risk of other comorbid conditions. Today, what we are talking, will be talking about the cardiovascular and the renal only. And also, there are other factors which can be increased, but today I will be talking and restricting to over this thing. So, if we have to talk about the pathophysiology, there is close association between the renal and the cardiovascular pathophysiology in type 2 diabetes. In CKD patients, generally there is either glomerular or the interstitial damage. In heart disease, it can be ischemic or the hypertrophy of the lung. So these are the cardiorenal risk factors which are common in individuals with type 2 diabetes. And there are studies which says that there is 2 times increased risk of heart diseases and the macrovascular diseases in patients with diabetes. And there are not very much molecules which can help us in reducing this. And again, it is an epidemiological data which says that 65% deaths are due to CV diseases, and coronary heart diseases increases by 2 to 4 times, and heart failure increases by 2 to 5 times, and stroke increases by 2 to 4 times in patients living with diabetes. And there was a old study in 1998 by Hafner which says that if the person is having diabetes, it is having the 7-year risk of myocardial infarction, almost equivalent to the person who had one episode of myocardial infarction without diabetes. So in these two, we can say that the person is not having MI but diabetic. It is almost is a equivalent risk factor for myocardial infarction. And this is the pathophysiological pathway that several parameters are involved in this cardio metabolic risk. So when there is diabetes, hyperglycemia, there is endothelial dysfunction, homeostatic disorders, angiopathies, fibrosis, and the several abnormal metabolisms are there, leading to the cardiomyopathies and coronary artery disease, which may lead to ischemic, non-ischemic cardiovascular diseases. And the patients with diabetes have significantly increased risk of death, coronary heart disease, and hospitalization because of cardiovascular or cerebrovascular diseases. And this was the study which have shown this. So, diabetes is a risk factor for cardiovascular diseases. So, there should be the molecules which we give for controlling blood sugars, blood glucose levels, which should not be harmful. After 2008, FDA, when the molecule few molecules have shown that it increases the risk of hospitalization because of heart failure, then FDA came up with the strict guidelines that any new molecule which is coming for the management of diabetes should show the CVOT trials, cardiovascular outcome trials. So recently, which molecules which we are using are the DPP-4 inhibitors, which are very good molecules. So there are the trials, the Severtimi trial with the saxagliptin, Examine trial with the allogliptin, Tecos trial with the sitagliptin, which has shown that these are non-inferior and these molecules doesn't increases the cardiovascular risk when we are managing the blood glucose, plasma glucose levels in our patient with diabetes. So it can be used safely. But new insight came with the SGLT2 inhibitors in the management of diabetes. So these molecules have shown that when compared to the placebo, the hospitalization because of heart failure significantly reduced when the patients were on SGLT2 inhibitors as compared to the standard trials. So then the dapagliflozin came with the trial of the DAPA heart failure trial, DAPA HF trial, which have shown that even in non-diabetic patients, the cardiovascular events are improved. So the dapagliflozin and the SGLT2 inhibitors are associated with a lower risk of hospitalization because of heart failure, or the 3-point MACE, and the all-cause mortality. So this was the meta-analysis of all the SGLT2 inhibitors. Here we can see that all the graphs in the forest graph, all the bars are on the left side, that is on the less than 1%, which says that it significantly improves the outcomes in the cardiovascular events when the patient is on SGLT2 inhibitors. But these molecules has to be used cautiously because few side effects are also there. So it has to be discussed, which I will be talking about in the later. Now, another molecule which we have in our armamentariums are the GLP-1 agonists, and there are trials with the lixisenatide, liraglutide, semaglutide, both injectable and oral form. Then the Excel trial with exenatide, albiglutide, and the dulaglutide, which says that these molecules are non-inferior, at least in few trials they have shown superiority, but in few trials they have shown non-inferiority in 3-point MACE, and they have reduced the risk of cardiovascular events and hospitalization because of the heart failure. So now coming to the another topic, that is the renal CKD, chronic kidney diseases. So diabetes is a leading cause for chronic kidney disease also. This was the, and since 1980s, the annual reports have shown that this graph difference has increased. The patient living with hypertension, the prevalence have increased. With cystic kidney diseases, glomerulonephritis, may have not increased significantly, but with diabetes and hypertension, it has increased significantly, and diabetes have the topmost corner, and maximum people are with the diabetes are having chronic kidney diseases. The possible etiology may be that life expectancies have increased, we have better cure. So as we know that as the duration of diabetes increases, risk of micro and macrovascular complication increases. That may be possible etiology, pathophysiological reason that prevalence of CKD have increased in patients with diabetes. And also, if the blood glucose, plasma glucose levels are not well controlled, it can lead to damage of the interstitium, the glomerular and tubules. And the data which says that the prevalence of CKD has increased from 9.2% to 9.6% in 10 years. Diabetic kidney disease is common, almost equally common in type 1 and type 2 diabetes. And the progression from to renal diseases to end stage renal diseases is approximately 10%, and several patients require dialysis and kidney transplantation. And death attributed to diabetic kidney disease increased by 94% from 1990 to 2012. And in India, it may be 5 times higher. No actual data is there, which may be because we have now molecules like SGLT2 inhibitors, GLP-1 analogs, DPP-4 inhibitors, which are improving the cardiovascular outcomes. And there was so many interventions in cardiovascular diseases that the deaths which might be happening earlier because of the cardiovascular diseases have reduced, and now the patients are progressing towards the diabetic kidney diseases. So it might be one reason, but other pathophysiologies may have to be looked after. So earlier we used to define CKD only on the basis of the EGFR. That if the EGFR is more than 90, then it is normal. More than 120, stage of hyperfiltration may be there. If it is between 60 to 90, it may be mildly reduced. It's G2 stage. G3 is between 45 to 59. G3 was between 30 to 40, and G4 15 to 29, and end stage renal disease failure when the EGFR was less than 15. But now newer thing has been added since 2008, 2012, that we should also look after the albuminuria. And if the patient is having albuminuria of less than 30 milligram per deciliter, then it is normal. If it is 30 to 300 micro, it is what earlier the term was micro albuminuria, now it is termed as moderately increased. Now, and if it is more than 300, then it is severely increased albuminuria, because it is just a homogeneous graph, and it is, we should not term these as value cutoff values. So now the term is moderately increased and severely increased. And if the patient is falling in these dark red graphs, then it is it is more severe CKD, and we have to take very hard interventions. What is the pathophysiology regarding development of kidney diseases in the patient with diabetes? It can be metabolic, it can be hemodynamic. So when there is hyperglycemia, there is advanced glycation end products, there is oxidation, there is glycations of the interstitium, of the muscles, of everything, endothelium. So if there is affected intracellular signaling, which affect the growth factor, cytokines, and the kidney size initially increases, which we know that kidney size, the three or four causes only in which the kidney size increases initially. One is diabetes, another is sarcoidosis, another is renal cystic diseases. In other CKDs, generally the size of kidney reduces. So it becomes an important DD when on sonography we are finding that the size of kidneys have increased. And whenever hemodynamic, the pressures gets deranged, the afferent and efferent arterial pressures get deranged, the renin-angiotensin system gets deranged, and because of this, there is fibrosis, and once fibrosis happens, there is renal scarring, and once renal scarring sets in, then there is the shrinking of the kidneys, and then the actual picture of shrunken kidneys come. So, till now, what we have, once we have diagnosed that the patient has developed chronic kidney disease or is in a stage 2, stage 3 of chronic kidney disease, then standard care was we had to individualize the target of HbA1c, and generally we used to keep the target of HbA1c around 7. We target to have good hypertensive control with good BP control, less than systolic BP should be less than 130 and diastolic should be less than 80. RAS inhibition, because we know that because of the hemodynamic changes, renin-angiotensin pathway is getting activated, and if we give RAS, then it may improve in reducing the albuminuria, it may improve the hemodynamics. Good lipid control. So even after having this standard care, which was a time-tested approach, the outcomes were not very much improving. So again, the wonder drug, SGLT2 inhibitors, they have shown that reduces the progression of kidney diseases, in which they have looked after three important outcomes. That what was the progression, worsening of nephropathy, new onset macroalbuminuria, how many patients have to go and progress to the end stage renal disease requiring dialysis or replacement therapies, and how many patients the doubling of serum creatinine levels was there with EGFR reducing to less than 45 ml per minute per 1.73 meters square. So there was significant reduction in the patients over the period of 52 weeks, in which they have seen that there was significant reduction in all these important parameters. So empagliflozin came up with the first study. Then they have also shown that there was regression in the macroalbuminuria from to microalbuminuria in significant number of patients over the period of 48 months. Then the hard points which they have looked after, that the patients, those who were having CKD, and they have looked after the cardiovascular events also in 2,250 patients, which have shown that the cardiovascular outcomes also improved in patients with CKD, those who were on empagliflozin with the EMPA-REG outcome trial. So, SGLT2 inhibitors significantly reduce the renal outcomes, complications also, and the cardiovascular complications also in different patient group, and in the patient those who were having both the things also. So then there was a trial with the canagliflozin also, Canvas trial, which have shown same results, that there was significant reduction in progression of albuminuria, regression of macroalbuminuria, and the progression of patients to end stage renal disease or renal deaths was reduced by 40%, which is a huge number. So SGLT2 inhibitors are the wonder drug. And then there was the Declare-TIMI trial, which has shown basically data with the cardiovascular outcomes, but the secondary and meta-analysis have shown that it definitely reduced the renal composite outcomes also. And then there was a DAPA-CKD trial after looking after the results of the Declare-TIMI. They have shown that dapagliflozin significantly reduces the albuminuria in patient with diabetes and hypertension on the top up of the standard care which was advised in 2012. So even after having good glycemic control, starting the patients on ACE or ARBs, having good blood pressure control, having good lipid profile, and when the dapagliflozin was added, there was significantly reduction in the patients, those who are progressing to the albuminuria. The mechanism for SGLT2 inhibition, renal protection are multiple. There are direct and indirect effects that it improves the glycemic control, indirect effects. So if glycemic control is there, well, insulin levels will come down, then the IGF levels may come down, the weight loss is there, so insulin sensitivity improves, and it may help in improving the erythropoietin levels, uric acid levels reduction, and as it causes diuresis, it may help in reducing the blood pressure also. And direct effect is seen because it prevents hyperfiltration, because it reduces the intraglomerular pressure, because it dilates the afferent arterioles. And it may, once the pressure is reduced, the prevention of the glomerular injuries is there, and the hyperglycemia which was there, which was leading to glucotoxicity, leading to inflammation, and reactive oxygen increase in the reactive oxygen species is reduced. So SGLT2 inhibitors have both cardiac and renal protection effect, which have shown in several studies. And the mechanism is very simple. It causes good glycemic control. It causes natriuresis, so it controls both glycemic homeostasis also and the hemodynamic homeostasis also. So now the future outlook is in renal patients is that if we are giving SGLT2 inhibitors, it is reducing the glomerular pressure by afferent vasomodulation. Here you can see that there is reduction in the diameter of afferent arteriole. So less of the fluid blood will be coming, so pressure will reduce. In RAS, there is dilatation of the efferent arterioles. So if more blood will be going out, so the pressure will come down. And if we combine both the things, then the chances are there that which may help in further reduction in the intraglomerular pressure. So the stage of hyperfiltration which comes in initial stage may be prevented, and this progression of progressive cascade of renal pathology may improve. So SGLT2 inhibitors reduces the deaths, all-cause mortality, and improves the cardiovascular outcomes with or without kidney diseases at the baseline. So this is the meta-analysis of EMPA-REG outcome trial, Canvas, Declare-TIMI, and Credence, that we can see all the bars are on the left side, which is odds ratio is less than 1, and it is improving the patient's whatever the EGFR levels are there, it is improving. So now we have seen SGLT2 inhibitors are the wonder drug. GLP-1 analogs are also very good molecules which have shown with the lixisenatide, liraglutide, semaglutide, exenatide in their studies that they reduces albuminuria, and it may help in reducing the progression of diseases. The primary outcomes were not with the renal, but the primary outcomes were basically for the cardiovascular events, but sub-analysis have shown that these definitely it may improve the renal outcomes. So now the SGLT2 inhibitors, few SGLT2 inhibitors can be given even till the EGFR of 15 or 20. But GLP-1 analogs, there is some still restrictions is there with the dulaglutide, exenatide, and that EGFR should be more than 30. But there is limited data with liraglutide, semaglutide in end-stage renal diseases. But but the real world evidences says that there is generally no dose adjustment is required, and it can be given even in end stage renal diseases. So we have molecules which help in reducing cardiovascular outcomes, improving the kidney outcomes. So SGLT2 inhibitors, GLP-1 receptor agonists, ACE inhibitors, statins. So these are the molecules which definitely we can see these are improving our outcomes in all the patients. So there is need for the joint approach because CVD and CKD go together. Lifestyle intervention is the crux. Glycemic control is very important. Along with that, we may use the molecules like GLP-1 analog, SGLT2 inhibitors, which may improve the outcomes. So at present, we are still searching for the novel treatment which can improve cardiorenal outcomes, but we have molecules which improve the outcome. Prevention is very important because we know that if we will hit heart early, then the risk of complications may come down. And then there are interventions which we can intervene early. We need some intervention which we can do early, which can prevent the common pathways of the disease. And the newer drug molecules are coming, like Filenon is the newer molecule in our armamentarium, which may prevent in progression of CKD, but the outcomes with the heart is not very, they are still coming up with the outcomes with the cardiovascular outcome. It doesn't have much good glycemic control, but yes, it can be given in type 2 diabetic patients. So, last few slides that we are having so many molecules, we have to choose best, which is best about for our patient. And the ADA guidelines also say that for now, our goal should be patient centric. We should discuss all the complications, all the factors which are best for our patient, and then we should go ahead. And this is now the ADA guidelines are very helpful. And if the patient is having high risk of heart failure or chronic kidney disease, they clearly says that we should ideally to proceed with GLP-1 RAs or SGLT2 inhibitors. If not, these are contraindicated, other molecules may be used. If the patient is having a risk of CKD also, SGLT2 inhibitors are proven molecules, and then we may switch to other molecule if these are contraindicated. And these are the ACE guidelines, which doesn't specify in what patient we have to give, but these suggest what how many molecules should be used if the according to the HbA1c target. In ADA, there is nothing like that. How many molecules should be started? They specify what according to the risk factors, they specify according to the HbA1c levels. So if we combine both these guidelines, it will be helpful. Suppose if the patient is coming for the first time, HbA1c is 8.5, we may directly start with GLP-1 RA and SGLT2 inhibitors with more lifestyle modification, because it may help in improving outcomes. Because there is a saying, two is always better than one. In our movies also, ek ek se bale do. But if HbA1c is less than 7.5, we may use one molecule according to the side effect profile of the patient. Thank you. Thank you for patience hearing. If any discussion, we can discuss here.
Presentation, a very important topic. I think we have Dr. Chong here joining in Ferry, I believe.
Good morning,
Dr. Chong,
sir.
thank you for joining in. He's the chairman for SIMAO. Dr. Chong.
Thank you, Dr. Jaideep Kare. Can you hear me?
Yeah, yes, sir.
Yeah,
Good morning,
perfect.
sir.
Yes. Thank you very much for your beautiful presentation. It's always good to see such a great summary of all the different molecules that we use on a daily basis. In Singapore as well, we have a huge number of diabetics. We have about 11% of the population who are diabetics. It's a huge challenge and it's growing every year. The number of CKDs and end-stage renal failures is also, I think we have more than 1,000 patients a year now, with a population about 5 million. And that's 1,000 patients a year going into end-stage renal failure. So this is a huge, huge problem. And we found that the semaglutides have been very, very useful. in reducing weight and so on, and getting them out of their pre-diabetic phase in a preventive manner. Thank you very much for your wonderful presentation. It's really, really up our alley.
Thank
Any questions from the floor?
Hi,
Sorry,
go ahead.
Enrique, I can't seem to find my hand to raise it. Thank you so much, Dr. Curry. This was an excellent presentation, and diabetes, as Dr. Chong says, is even in South Africa a big, big problem. However, I just would like to ask two questions. The role of sulfonylureas, is there still a role for that as first line? That's one of the questions, even second line. And then can you use, I just want clarity, can you use your semaglutide with your insulin, for your type 2 diabetes? And is semaglutide contraindicated for a type 1 diabetes? Thanks.
Okay, ma'am. So I will start from the first. The important question, sulfonylureas are the time-tested molecule, ma'am, and these are having the highest HbA1c reduction potential. And now the latest trial, which has compared sulfonylureas with the linagliptin, Carmelina trial, which has shown that it is non-inferior in cardiovascular events. So yeah, and the newer generation, second generation sulfonylureas, especially the glimepiride and the gliclazide, they have shown that they definitely helps in improving the ischemic myocardial ischemic preconditioning. So definitely still the first important factor is that there should be good glycemic control, and sulfonylureas are the most potent molecules. So still they have role. All the molecules which are in our armamentarium in management of diabetes have role either directly or indirectly. Now coming to your second query, ma'am, that in especially in semaglutide with insulin in type 2 diabetes. So yes, we are using, ma'am, and even GLP-1 analogs are approved by the European societies in type 1 diabetes. But the benefit with the when we combine both the semaglutide and all the GLP-1 analog with insulin, the benefit is there that the requirement of insulin doses come down over the period of 2 to 3 weeks, because GLP-1 analogs helps in weight reduction. They improve insulin sensitivity, and they so the risk profile of hypoglycemia, all the side effect of insulin, which we are mainly worried about, the weight gain, the chronic condition gets improved. So even in my practice, in few type 1 also we are using semaglutide, because in type 1 what we say that it is basically the beta cell failure. Alpha cell failures we don't know. So in GLP-1 analogs act on both alpha and beta cells. So type 1 patients are mainly the brittle diabetic patient that suddenly they go in just 1 unit, they may go into hypos, or even sometimes we are giving 20-30 units of insulin, they are not getting good glycemic control. So this glycemic variability goes down, but we should advise them that even in type 2 and type 1, the risk of hypoglycemia, that in near future after 48 hours or 72 hours, your insulin requirement may come down. And over to your these two and the any other query was there, ma'am?
No, thank you. Excellent answer. So, yeah, thank you so much. So we can use it safely in type 1 diabetes as well.
Yes.
I just want to know on the HbA1 reduction, you said that the sulfonylureas are the best. Which second one, if you need, except now for insulin, if you want to reduce the HbA1.
Yes, ma'am. I will say that I am practicing in a government setting where in India the patient has to bear the cost of their own medications. So if we have to talk about HbA1c reduction with different molecules, insulin have the highest potential. It is unlimited. Then the metformin, which has HbA1c reduction potential of 1.5 to 2%. Sulfonylureas, 1.5 to 2%. Then all other molecules are having HbA1c reduction potential of approximately 1 to 1.5. The weaker ones are the alpha glucosidase inhibitors, which have just 0.5 HbA1c reduction potential. And other bromocriptine 0.5% reduction potential is just imiglamin, which has came up recently in the market, 0.5. DPP4 inhibitor 0.5 to 1. SGLT2 inhibitors 1 to 1.5. So if we have to talk about but it should not be like that because we have to talk about what are our targets in how fast we have to reduce the HbA1c. So sulfonylureas, this is not somewhere written, but it is our practical experience that several times we have seen the newly diagnosed patients, those whose HbA1c are in 11, 12, 13, which we commonly see in India, because patients directly come to us with complications. And they are just like that, as guideline says that if HbA1c is more than 9.5 or the patient is having some complications, they should be started on insulin. But here patients are very reluctant to injectable therapies. So if we start with just sulfonylureas or triple drug combination, three drugs like DPP4 inhibitors and SGLT2 inhibitors with sulfonylureas, we have seen in 40-50% cases that after 3 months that 12, 13 HbA1c have came to 8 or 9 levels. So it is individual response, but overall the HbA1c reduction of sulfonylureas is approximately 1.5%. Thank you, ma'am.
Thank you, Dr. Kare. That was a very good summary of the various, comparing the various strengths of all the therapies.
Thank
Very,
you,
very
sir.
useful.
Thank you, sir. Thank you.
Any other questions from the floor? Well, if there are no questions from the floor, I thank Dr. Kare again for his wonderful
Thank you.
presentation. I really gained it's been a very good summary of everything that we've been doing in the last few years. And we look forward to having you back again on more topics, maybe related to these metabolic diseases, because they're really a huge problem in a lot of countries, whether it's first world, second world, or third world countries. So very, very much appreciated what you just summarized for us. Thank you.
Thank you. Thank you, sir.
Thank you.
For a very good presentation. We'll see you again next week with a new topic and a new speaker. Thank you, everyone. Thank you, everyone.
Thank you. Thank you. Bye.
Thank you. Thank you. Bye.
Thank you.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye.